Hello, good morning, and we'd like to introduce you, to welcome you to the first of series of webinars on understanding rights-based family planning. I'm Sandra Jordan, a Director of Global Advocacy Rights and Youth, and I have with me three experts in the field of operationalizing and analyzing and studying rights-based family planning. Looking from my left to the far left, I have Lynn Bakchamian, Jan Kumar, and Kaya Juchinska. Thank you again for joining us. And as we are in the midst of preparing for a 2017 London Summit, this offers a really good time to stop and think about the last summit in 2012 when the foundational idea of rights-based family planning was first put into play, and how we have moved in that 5 years from a framework to a strong understanding of how rights are can be centered in family planning, to looking more and more at how to operationalize this and to make it make sense to people working on the ground, people programming, people designing projects, and to donors looking for the most effective way of supporting family planning. So rather than continue talking, I'd like to turn this over to Lynn and let her get started on this.
Is that right?
Sorry.
Hello, everyone. This is Rati Bishnoi. I'm actually chiming in to just give a few notes on logistics during the webinar before we actually get started with the program. Again, thank you for joining us today for the webinar. First, we'd just like to say that in front of your screen, you should be seeing the presentation and two pods next to that presentation, one with the attendees and one for Q&A. Please, at any point during the presentation, use the Q&A pod to submit questions. We will have a brief Q&A portion at the end of the webinar. And if at any point you have any difficulty using that mode to communicate with us, please email info@familyplanning2020.org. Lastly, this webinar is being recorded and is going to be made available to all the attendees. Thank you. Over to you, Lynn.
Thank you, Sandra and Rati. Am I on? Okay. And thank you all for joining us today for what might be or will be the first in a series of webinars to discuss rights-based family planning, a topic of emerging interest in the family planning community. Today's objectives are to demystify the meaning of a rights-based approach to family planning, highlight what distinguishes a rights-based approach from what we would call business as usual, and the difference it makes. And this happens to be one of the most frequently asked questions we get about rights-based family planning. We'd also like to increase understanding of the benefits of taking a rights-based approach, as well as the risks of not taking it, and increase awareness of some concrete rights-supportive actions that programs can take by different stakeholders in order to operationalize rights. I'm not getting the mouse. There we go. Very sensitive. All right. We all know and are on board with the goal of Family Planning 2020, which is to reach an additional 120 million users with family planning information and services. Click. Here's a screenshot, if we can get the click to work. Yeah, it's very sensitive mouse. Yeah, there we go. Here's a screenshot from Family Planning 2020's microsite on rights-based family planning, which we hope you will become familiar with and use. Language about rights was adopted by FP 2020 from the start and is considered central to its vision and belief that investing in rights is critical to growing sustainable, equitable, and effective programs with lasting impact. So let's start with the basics. What are human rights and how do these relate to family planning? Human rights are entitlements that all people, men and women, have by virtue of being human. They've been enshrined in various treaties, international conference documents, and declarations, mainly under the auspices of the UN. And it is important to note that if a country has signed onto a treaty, then the provisions of that treaty have the force of international as well as domestic law in the country. Therefore, human rights have the law behind them, which gives citizens a tool for holding their governments accountable. And this, interestingly enough, this factor is a compelling point with national stakeholders and especially providers that they are obligated to respect and protect rights. But above all, human rights hold the dignity of the individual at its core. Here again is FP 2020's site, and as noted, there are three main pillars in rights-based family planning. One, individuals and couples can choose whether, when, and how many children to have. Two, they can act on those choices through high-quality SRH services, information, and education. And three, they have access to those services free from discrimination, coercion, and violence. Next slide, please. Rights-based family planning is essentially a shift that moves the focus of programs from numbers to people. It puts individuals at the center of the program and focuses on their rights to, again, decide freely and responsibly their number and spacing of children with quality SRH services to enable them to do so without facing discrimination or inequality. These three categories of rights contribute to reaching national and global goals. Therefore, a rights-based approach does not negate the importance of setting and working towards numerical goals. In fact, we believe that rights-based family planning is compatible with and indeed necessary for achieving those goals. Much work has been done recently and since the London Summit on Family Planning in 2012 to define human rights and those rights empowerment principles that specifically apply to family planning services. In this slide on the left, we have FP 2020's Rights and Empowerment Principles for Family Planning, which outlines common understanding of rights principles that FP 2020 believes must be respected, protected, and fulfilled in order to reach and sustain goals for meeting contraceptive needs. And this document is helpful as it provides a definition for each right and provides illustrative examples on how these can be operationalized. On the right, we have two documents developed by WHO and UNFPA, which provide guidance for policymakers and program managers on priority actions needed to ensure that human rights dimensions are integrated, as well as some implementation guidance. And in the center, we've pulled from these documents to identify the key principles outlined by both of them that we've used to inform current work to operationalize and measure human rights-based approach to family planning. So in these next three slides, I'll go through this pretty quickly. They provide definitions for each of the rights that were in the middle of the previous slide that apply to family planning. And these definitions are aligned with those documents we showed previously, but they've been somewhat simplified in a language that is easily understood by program stakeholders, providers, facility managers, even community members and clients. And this is based on current work by Palladium in Nigeria to test a rights-based approach in Kaduna State with Bill and Melinda Gates Foundation funding. So just to go through these quickly, agency, empowerment, and autonomy, where individuals have the right to make and act on their own family planning decisions, availability, accessibility, and next slide, acceptability and quality, concepts most in the family planning community are quite familiar with. Non-discrimination and equity, that individuals have the right to be treated fairly without discrimination based on who they are or their circumstances. Informed choice, another important tenet that the field has been working towards for many years. Privacy and confidentiality, that individuals have the right to receive information and services in a setting where no one can hear or observe their interactions with the provider and expect that that's respected and not shared with others. And the two last ones, participation and accountability. Participation, that individuals have the right to provide input into how family planning services are offered at their facility, including the ability to provide complaints, and accountability, that individuals have the right to speak up if any of their rights have not been fulfilled and expect that some action will be taken. So in this next slide, remembering a list of 10 rights and rights principles, or how many ever there are, is tough enough. So we created this graphic to pull it all together. At the top, the roof are the human rights conventions from which rights and rights principles flow. And we'll get to those in a minute. The next level are the three pillars which correspond to three main categories of reproductive rights as explained by or defined by two human rights lawyers, Erdman and Cook, who have written extensively on reproductive rights. And within these three pillars, it's followed by the related rights and rights principles underneath. So for example, on the left we have the right to reproductive self-determination, and underneath are the principles of agency, autonomy, empowerment, and informed decision-making, and so on through the graphic for the other two pillars. And at the bottom are the foundational principles of accountability and participation, which support and relate to all the rights and rights principles above. So this slide here basically is a bit of a word about the roof and the documents from which these rights flow. For example, the right to availability, accessibility, acceptability, and quality, also known in the rights community as AAAQ, are outlined and have been outlined since 1966 in the International Covenant on Economic, Social, and Cultural Rights, as well as a general comment on the right to health from 2000. The other rights below on the left are basically the three pillars we've talked about, and they flow from the ICPD, the Internet in 1994, the International Women's Conference in 95, and the Maputo Protocol on women's rights in 2003, as well as a more recent updated General Comment 22 for the SDGs on the right to sexual and reproductive health. So let's turn to, we've talked about rights and rights principles that apply to family planning. Let's talk specifically about what we mean by a rights-based approach. In a rights-based approach, human rights are the frame of reference or lens that helps define and drive what you do. For example, the goal is to give people control over their fertility by ensuring that their rights are respected, protected, and fulfilled within their experience of the family planning program. It empowers individuals to make and act on their own decisions. The focus centers again on people in the program that the program is meant to serve rather than numeric goals of the program, although again, it's not incompatible with having numeric goals. It embraces not only health systems issues, but also embraces their policy and cultural context. And in the approach, rights guide the way programs are designed, implemented, monitored, and evaluated. And it develops the capacity of those duty bearers, the government and other institutions, to meet their obligations, as well as empowers rights holders, clients, and prospective clients to know and claim their rights. Again, one of the most frequently asked questions is how does a rights-based approach differ from what we normally do? So this graphic is meant to help illustrate that the added principles inherent in a right-based approach go beyond what we normally do. In the ovals on the left, we have what we might call business as usual in many programs. Family planning programs started with basics of assuring supply and demand through activities designed to make services available, accessible, and acceptable. And this was followed by an understanding that it was important to assure quality, voluntarism, choice of methods, and privacy and confidentiality. These principles, while not always adhered to, are strived for in family planning service delivery. A rights-based approach goes somewhat beyond this programming to address available, accessible, and acceptable quality services and considers who isn't being served and why. Is it a matter of discrimination? Is it a matter of lack of equitable distribution of health resources? Sociocultural norms that impact the agency of women and girls to get what they need and want? Further, programs that address rights also have mechanisms in place to support participation of potential clients and to take into account their voice in the design of programs. Programs and services are held accountable for respecting, protecting, and fulfilling rights, and individuals are entitled to seek remedies and redress if rights are violated. This graphic is intended to show that program attention to access and quality and the things that we hold dear are necessary components, but not necessarily sufficient for implementing a rights-based approach to family planning. One overarching consideration when working to operationalize a rights-based approach to family planning is to be sensitive to the very real resource constraints that programs face. Within a rights-based framework, there is the concept of progressive realization of rights, and this accounts for the fact that countries and programs are at different starting points and that there exist many constraints to the fulfillment of rights for everyone. The point of progressive realization is that governments and implementers should take whatever steps they can that are possible to advance human rights while moving progressively towards the ideal. In other words, resource constraints are not an excuse for doing nothing. So now I will hand it over to Jan.
Thank you, Lynn, and welcome everybody. Okay, as Lynn has explained what we mean by human rights and a rights-based approach to family planning. Now we're going to turn to the rationale for taking this approach. Why? Next, please. Well, for starters, a combination of attributes make family planning different from other healthcare services. It's an elective preventative healthcare service. It is related to sexuality and fertility, which involve religious and cultural sensitivities, gender and power dynamics. And because it has population implications for things like the economy, social services, governments set goals for family planning use. In addition, family planning is vulnerable to a number of conditions that can compromise human rights. There are access barriers that prevent many people, particularly the underserved, hard-to-reach, unmarried youth, and other marginalized groups, from getting the contraception they want. There are also coercive pressures, some subtle and some overt, that push people to accept family planning or specific methods that they don't want. And then there's the problem of poor quality, which includes lack of respect for clients' dignity, privacy, or confidentiality, inadequate counseling that undermines informed and voluntary choice, and substandard clinical care. People generally recognize overt coercion as an egregious human rights violation. Cases of blatant coercion that you will see in the upper right-hand corner of this grid, like the involuntary sterilization of HIV-positive women, the insertion of IUDs postpartum without a woman's knowledge or consent, or the refusal to remove implants, rightly draw outrage. But preventing such cases is not enough. Many factors challenge human rights. Some exert subtle pressures that push people toward accepting family planning, as I mentioned. In addition, there are challenges to equity, availability, and access. Some are overt, some are subtle, and some are inadvertent. But these problems are widespread and pose barriers to people getting the information and services that they do want. And there are examples of that in the bottom two quadrants of this grid. So we need to look beyond the obvious to recognize and address all challenges to rights. When thinking about why to take a rights-based approach, it's important to discuss the benefits while also considering the risks of not fulfilling rights. Because this is an emerging area of program interest, the benefits are currently under study in order to generate evidence to help policymakers and program managers make informed decisions about adopting rights-based approaches in their programming. At this time, there are pilots underway in Nigeria, Uganda, and Cote d'Ivoire, which should be yielding results later this year. But at this point, we have reason to expect that a rights-based approach in terms of benefits will advance our progress toward universal access to family planning. We have reason to believe that it will improve program outcomes and effectiveness, improve accountability to clients and communities, and as a result, protect programs' reputation with communities and increase sustainability. On the flip side, the risks of not fulfilling human rights include the continuation of marginalized and vulnerable groups not being served, the inability to foresee the unintended consequences of method or numbers-driven initiatives, lack of trust and support from the community, and poor reputation among donors, which can lead to funding decreases. Another way to think of the benefits of this approach is to ask the question, what's in it for me, from different perspectives? So here are some benefits for 4 categories of stakeholders. With a rights-based approach, an individual can expect that no matter who you are, you get the information and services you want to achieve your reproductive intentions. You're treated with respect, and you are empowered to make and act on your decisions, free from coercion, discrimination, and violence. If you're a service provider, you can expect that you will enjoy the trust of your clients and the support of your community. Government and donor representatives can expect enhanced and accelerated program outcomes, increased sustainability, and protection against negative, unintended consequences that can undermine a program. And if you're an implementing agency, you get an approach that unifies and guides all the elements of a holistic quality family planning program. As noted in that last point, this graphic shows that all the program components that we've all been working on for years are rights supportive, and they contribute to comprehensive programming. A rights-based approach can therefore serve as a unifying, overarching construct that ties all the pieces together. It should not be thought of as a siloed technical area. Okay, so let's talk a little more about the practicalities or the how of applying a rights-based approach. It's important to take a holistic perspective that considers factors at all levels of the health system. In addressing family planning goals, we have a tendency to focus on service delivery and to overlook factors at these other levels. So we're thinking about the policy level, service delivery level, community, and individual levels. This slide is based on the Voluntary Rights-Based Family Planning Conceptual Framework, which is a programming framework that translates rights concepts into familiar programmatic language. It offers the essential conditions and elements that are needed at these various levels to operationalize human rights in family planning. I should note that several years ago, the United Nations adopted a rights-based approach for all of its work across all UN agencies. Its guidance is consistent with this holistic approach. This particular framework is laid out in the format of a logic model. It shows that much that is needed is already in place, and that we don't need to totally overhaul our programs to make them rights-based. However, it provides a lens through which to consider what is working well and to identify weaknesses and gaps that might be hindering the fulfillment of rights in family planning. It also helps you map where your strengths and mandate fit into the whole and where you may need strategic partnerships, because no one agency or project can do it all. I also want to note that a rights-based approach is not what makes programming complicated. Healthcare systems are complex, and programming for holistic programs is complicated, rights-based or not. So to bring this to life, let's look at a couple of vignettes through a rights lens. I'm going to quickly read this first vignette, which focuses on ambitious national goals. The government of Andoria has made family planning a national priority. Current CPR is 23%, with 75% of the current method mix attributed to pills and injectables. Andoria has committed to a CPR goal of 50% by 2020, in effect doubling current prevalence and requiring an annual increase of 5%. This goal is supported at the highest levels of government, with visible calls to action from the President and Minister of Health to all districts. The major activity to support this goal is the training of providers in IUD and implant insertion, although there hasn't been sufficient caseload to support practical training in implant removals. In Andorita District, the supervisor focuses mainly on reviewing the clinic register and encouraging facility staff to increase family planning uptake, especially of long-acting methods. The supervisor spends little time discussing other issues, such as lack of equipment, supplies, and educational materials, delays in salary payment, low caseload and demand for family planning, and requests for removals. As a result, providers are taking up the benefits of LARCs with family planning clients, especially among poor women, as they are considered not as likely to effectively use short-acting methods. The clinic charges for removals, although insertion services are free. So an analysis of this scenario reveals challenges to several rights-related principles. Next slide, please. Again, okay. So here we have some of the rights-related principles that are challenged in this case. Availability and accessibility, we heard that there are financial and other barriers to implant removal. Quality, there was rapid and incomplete LARC rollout with inadequate supervision and focus on quality improvement. Agency, autonomy, and informed choice have been compromised by method-specific promotion, where program and supervisor focus on uptake results in provider pressure and bias. And there's evidence of discrimination. Poor women receive more directive counseling than other women. Now, if we were to look through a rights lens, here are some illustrative program actions that could be taken. Advocate to policymakers for the promotion of free informed choice. Support training for forecasting family planning services to ensure realistic goals and adequate financing for rollout. Review fee structures to ensure affordable access to removals. Strengthen counseling to make it unbiased and client-centered, and make human rights explicit in training, service guidelines, provider job descriptions, and supervisory tools. We have time for the second scenario? Yeah? Okay. I'll whale through the second case. Here's the second situation that depicts another common situation. REENA is 15 years old and lives in a farming community. Her parents are arranging for her to marry a merchant's son. REENA has other plans. She wants to be a teacher. She has a boyfriend, Kazim, who's pressuring her to become intimate. REENA is conflicted about opposing her parents and is afraid of becoming pregnant, although she doesn't understand how pregnancy happens or how to prevent it. She's had no sex education in school. REENA notices a poster on the street for a new teen hotline, and she calls the number. She's referred to the local primary healthcare clinic, which she finds to be crowded with mothers and babies. She's led into a small area which is open to the waiting room. REENA is embarrassed, so she complains of an imaginary headache. While the nurse takes her blood pressure, she tells the nurse that a friend of hers has a question about how to prevent pregnancy. The nurse looks disapproving and asks, "How old is your friend, and is she married?" REENA replies, 16 and not yet married. Then she shouldn't be having relations and doesn't need prevention, says the nurse. With this, the conversation ends. REENA leaves, disappointed and confused. So again, in this vignette, multiple human rights principles are being compromised. Availability, accessibility, and acceptability are being challenged by lack of information and services geared toward the needs of unmarried youth. Privacy and confidentiality is compromised by counseling being offered in a public area. The provider is judgmental, discriminates against unmarried youth. They're not treated like other clients, so that's an equity issue. And the cultural norms in this situation do not support female empowerment, autonomy, and agency. So here are some actions that could be taken if you are thinking rights-based. Review, revise policies and plans, and advocate for resources to support sex education and youth-friendly family planning services. Support social and behavior change communication campaigns to influence social and gender norms and promote awareness of women's and girls' rights to reproductive health information and services. Train or retrain providers in counseling and include rights literacy and values clarification. And revise job descriptions and supervision protocols to ensure the providers are accountable for respecting, protecting, and fulfilling human rights, including non-discrimination and equity. Now, some of you may remember that there was an ad a few years ago from the Apple Computer Company. Think different, it said. This is a fitting notion here. As previously noted, taking a rights-based approach requires thinking beyond business as usual. It involves identifying different challenges in family planning programs than we otherwise would, and coming up with different solutions in order to protect and fulfill individuals' human rights. Here are some of the typical program interventions that we are all familiar with, and some different ones that might be taken if a rights lens were applied. So you can see here, typically we develop policies to support family planning access and quality, and to remove unnecessary medical barriers to contraceptive use. If you were thinking rights-based, you would ensure that policies explicitly reference human rights and align with service guidelines and protocols. You would review who is and is not accessing services to support equity. For training, we normally train in clinical and counseling skills. Rights-based training would include rights literacy as part of this basic training. We normally strengthen supervision to support quality management and improvement. In rights-based programming, we would ensure provider performance expectations and supervisory protocols include human rights, and we would include client and community feedback mechanisms. Typically, we support demand creation activities, including community engagement and mobilization. Rights-based would include the promotion of women's and girls' rights in SBCC activities and implement interventions to address gender and sociocultural barriers. And we normally strengthen monitoring and evaluation systems to support stewardship, management, and accountability. With a rights-based lens, we would ensure that family planning strategies include accountability and redress mechanisms and ensure the use of protocols for investigating and managing alleged violations of rights. Numerous resources now exist to help people apply a rights-based approach. Many guidance materials have been published just over the last 5 years. Now this slide shows in the middle the FP 2020 microsite on rights and empowerment, which is very helpful and has links to many resources. One of them is a compendium put together by USAID-funded, the USAID-funded Evidence Project, which lists the main resources available for programming a rights-based approach in contraception. And this one is shown on the left. It was recently updated in April, so it includes the latest resources. FP 2020 has also developed a toolkit for designing family planning programs that respect, protect, and fulfill the rights of women and girls, which you can see here on the right. Now we will hear 2 very recent and different field-based experiences applying a rights-based approach to give us a sense of what it looks like in practice. First, we will hear from Kaya from Palladium about a project that she manages in Kaduna, Nigeria. Then we will hear from Sandra about an experience at the FP 2020 Asia Regional Focal Point workshop that took place just a couple of weeks ago.
Hello, and I'm just breaking in real quickly. This is Sandra. To remind people to submit questions. We always get a lot of questions on this, and so I wanted you to hurry and get yours in so that we can get to them when we get to the Q&A. And so send in those questions. And now, Kaya, back to you.
Thank you very much. And if we can go on to the next slide. Lovely. Well, good morning, everyone. And I'm very happy to share with you highlights from Palladium's voluntary rights-based family planning project, which is designed to generate evidence on how implementing a family planning rights-based interventions affects health and rights outcomes across Kaduna State, Nigeria, as was mentioned earlier. So I'm going to be profiling one of our many intervention activities, and this one is focused at the community and individual level, which Jan distinguished a little earlier. So under this intervention activity, we built the capacity of facility health committees so that they have an improved understanding of their responsibilities, and also so that they gain an appreciation for family planning and human rights and feel empowered to execute their roles with family planning and human rights in mind.
You may wonder, what is a facility health committee? That's a good question, and it's a group of 15 community members within a catchment area of a local primary health care facility, and they're charged with 3 key responsibilities. One is to collect community feedback on health problems, on their concerns, on any issues that they're having using services. The next responsibility is to work to improve and oversee health facility performance. They monitor, for instance, stockouts, drug sales. Lastly, they mobilize the community to access the services and experience the service standards to which they are entitled. So you can see here that an FHC, or a facility health committee, is very clearly an accountability and a participation arm of the rights-based approach. We had an opportunity to train a total of 16 facility health committees, which is over 225 people, and the training lasted 3 days. One day was on roles and responsibilities, one day was on family planning, and one day was on Human Rights 101. Sandra, could we go back to the previous slide? Sorry. So what did we experience during this training? Well, I'm really happy to share that there really was an aha moment for FHC members. By linking family planning and rights modules, we were able to elevate the day-to-day conditions experienced by individuals, like age or marital discrimination, issues around privacy and confidentiality. We were able to elevate them as rights issues. These are not things that should be happening on a daily basis. And this ignited powerful commitments to action by each of the FHC members. And we profile some of those commitments here. I'm not going to read all of them, but just one as an example. An FHC member says, I'm going to ensure clients are treated with courtesy and respect, that they receive good clinical care and experience non-discrimination and equity. I will also ensure that the FHC puts in practice all that they have learned. And maybe just one more here. I will ensure that client privacy and confidentiality is adhered to in the PHCs at all times, and to let them know that that is their right. So these are very powerful commitments. And if we move on to the next slide, not only was the commitment to action ignited, but we're gathering evidence actively on how these pledges are being realized. And we do this through mentorship and follow-up, where our mentors call or visit each of these facility health committees and provide one-on-one technical assistance, if you will. What actions have we seen so far? Well, the good news is many. We're seeing that facility health committees have already started sensitizing community leaders and influencers on family planning and rights. They've also begun holding visits in order to identify key issues faced by the community. So they have something called community dialogues. They take trips into their areas and talk with people one-on-one to hear about the service challenges that they're experiencing. And now they're also raising resources for underfunded facility needs, like IUD kits, improvements to privacy. And these are helping to overcome entrenched health system challenges. As we know, so often the public sector just isn't able to or does not put funding in health where it's needed. And finally, we're seeing follow-up on individual commitments, and you can see those statements here along with the pictures from our training. And just one example of a follow-up on a commitment, an FHC member writes that she sensitized her family members and women in the Islamia school on the benefits of family planning, and that 2 of these women from the Islamia school became interested and referred by her to the facility, and they have visited the facility and accessed the services. We're still in the early stages of monitoring follow-up from our training, but we certainly will be gathering more of these examples. And we hope that this, at least for now, underscores the importance of building awareness not only on family planning, but on family planning and rights at the community level, and unlocking and creating this aha moment. So we look forward to sharing more information on that part of the intervention in the future. Thank you.
None of the countries really had rights-based family planning in their programs. in their action plans and their costed implementation plans. And so we did a very similar presentation to this, although it was about 2 hours long, with, so it was much more in-depth and more a lot more feedback from the audience. But when at the very end, when the countries were getting up and doing their 2-minute presentations on what their CIPs and action plans would look like, they all mentioned either rights-based family planning, or in the case of countries that don't have a rights framework guiding their country, they talked about Quality Plus and client-focused family planning. And we had this really great delegation from Afghanistan who stood up, and their entire CIP was completely focused around rights-based family planning, and they actually used the model of the, we call it the Temple of Rights, but the Human Rights Conventions, the roof with the 3 pillars under it, to push everything through. And when you think about Afghanistan 20 years ago, when women couldn't even leave the house and girls couldn't go to school, that Afghanistan is now doing a rights-based approach because it makes so much sense, is really gratifying. And the other countries were doing the same thing, and it was a great experience. So that's right now. And hang on.
All right. No, one back. No, that's right. We're in the right place. Okay. So to conclude, we are proposing that we collectively need to reframe the way we think about and go about family planning programming. Being intentional about human rights involves a shift in focus from methods and numbers, Sandra, thank you, to individuals' needs, next one, and their rights. Now, we are still building the evidence base, but we have reason to believe that applying this approach in the way we design, assess, manage, monitor, and evaluate programs will yield better outcomes both for individuals and for program performance. This will help us meet our FP 2020 and Sustainable Development Goals. So, in closing, we would just like to acknowledge and thank that these slides have been developed over the last several years with the support of a number of donors, organizations, and projects, which are listed here, as are some of the key individuals who contributed to this presentation. We will wrap with that.
And I'll remember to turn on my microphone this time. Thank you very much, Lynn, Jan, and Kaya. And we are now going to turn to the listeners, to the audience, to get your questions and comments. And we actually have a couple of questions now. Kaya, this one's for you. Sarah Jeffrey wants to know how the FHC members selected, how are they selected, and what incentives are given, if any? And how is the relationship of the FHC and the officers in charge of the clinics? How is that relationship?
So firstly, I'll start with the second part of that question, which is that they receive no incentive other than kind of doing good for their communities. There's no financial compensation. There's no kind of stipends. How they're selected, it's supposed to be through a democratic kind of community process. So individuals in the community are sensitized most frequently by the in charge of the facility, and then they have kind of a self-nomination process in order to join the FHC. So it's quite organic. And the third part of that question, I'm sorry, was? Let's see, is it part of, I'm sorry, I moved on. It's how is the relationship with the FHC and the officers in charge of the clinic? That's a great question. Thank you. So sorry for forgetting that one. So the 15 members, one of them actually is the facility in charge, which is fantastic because the head provider from the local facility sits and works alongside the other members of the facility health committee. And so there's kind of active feedback and an opportunity to share with the facility very directly some of the kind of grievances, concerns, and experiences of community members. So your ability to provide feedback that will hopefully be acted upon is much improved through that relationship. Any additions from you, Lynn and Jan?
Thank you so much. From Kate Rademacher, we have this question. Are commodity stockouts and or a lack of access to a full method mix explicitly included in a rights-based approach? For example, is it part of the equity component?
Well, I'll jump in and you can add. I think of it as an access and availability issue, and the way that the right is expressed in many documents is that people should have access to the widest possible range of services. So what services those are not specified, but there is an obligation for programs to try to increase and expand the range of methods that they offer and to ensure that they are regularly available so that people can actually exercise informed choice and get the methods that they want. So if there are problems either with the method not being offered at all or not being available at all sites, or if there are stockout issues, that challenges several rights.
I'll just want to add one. I just want to add one more thing, and it's that idea of progressive realization. I think your question used the full method mix, and as we all know, that's almost impossible for many programs, but we should be working, as Jan says, towards broadening the method mix as much as possible so that there are a range of different types of methods, different characteristics that would then align to different reproductive intentions and needs among clients.
Thank you. I have another one, and I think you can help with this one, Kaya. Does a rights-based approach involve a lot more work and cost?
What a great question. I'd like to say note both of those. I think on the second we'll be doing some more thinking, at least on the project in KADUNA, to try to quantify our level of effort, if you will, in terms of working with the public sector. But overall, no, it doesn't take a lot of extra effort. What it requires is reframing and a little bit more work up front, which is in the form of kind of more comprehensive pre- or in-service training, and really making providers, especially for thinking about the facility level, making them aware about these kind of softer components to health services, the rights issues. And so that in and of itself does take some effort, of course, because you need to have the curricula, you need to integrate it. But luckily, on the KADUNA project, we've had the good fortune of working with Lynn and Jan, who have developed one such curricula for us. So we're looking forward to sharing that more broadly. But my experience is that it doesn't take a lot more effort, and it doesn't cost a lot. It's a matter of reframing for service providers and including some of the softer kind of rights dimensions in the communication materials that are already being used at the community and individual level. But I think Lynn and Jan can add a lot more to that.
I just want to add that doing good programming, as I think Jan said earlier, doing good programming, holistic programming that takes into consideration all the things that will result in effective service delivery is difficult. Adding rights to that isn't necessarily where it's hard or costs a lot, but dealing with all the other issues one needs to deal with to do good service delivery, supervision, contraceptive logistics and management, all of that stuff that many programs are already paying attention to is where it costs and where it's hard. Putting a rights lens onto that hopefully can help and not be considered a burden.
Just to add that what we're really talking about is a mindset shift. We will be doing many of the same things, just doing them with a different perspective. Looking through this lens just makes you think about things you might not otherwise consider. Reflecting back on the slide that had the grid, many programs believe that if they don't have problems with coercion, they don't have problems with rights. And we're just trying to broaden the thinking and make people aware of what rights are, aware of what their responsibilities are in protecting and fulfilling them, and being intentional in applying this lens as you go about the work that you do anyway. And again, much of what we've been doing for decades now, everything related to informed choice and quality and youth services and engaging men, all of that is right supportive. So what we need to do is build on the good work that we have been doing, but just being aware of the extra elements that we may not be attending to unless we take this perspective.
Thank you. Now I have a tough one from Beverly Johnson. From the presenter's experience, where do you see the most progress in designing and implementing supportive policies and programs? Second part, what issues, approaches, and policies are most challenging to program designers and implementers?
Here. Oh, I've got one. All right. Well, this is Lynn, and from my experience, I think the most progress we've seen is in having providers, because most of the work that I've been involved with is at the service delivery level and working with service providers on rights literacy. And most of the progress I've seen is that in that aha moment where providers realize that what they have been doing has been more directive and more biased because of the pressures that the programs themselves have put on them for achieving certain program goals. So, for example, in programs that are introducing IUDs and implants, what has happened is that translation of making choice available has somewhat resulted in what we would call a subtle pressure to elevate those choices when talking to clients. And so there's this aha moment when we, present some of these materials and talk through values, clarification, and other things where providers themselves are going, oh, I see, I shouldn't be doing that, or oh, I see, I need to be more neutral. I shouldn't put my own perspective on this client. So I think that's one area where this has been meaningful to providers in looking at their behaviors as they relate to clients. On challenges, anyone want to, Jan, you want that one?
Just to build on what Lynn has said, we have introduced this approach at different levels. And one of the challenges is to have it cascade. You can see policymakers come on board, and they may be committed to a rights-based approach in the language that they use in their policies. But then, as Lynn said, they may adopt some policies that inadvertently undercut a rights-based approach when you get down to implementation. Things like promoting specific methods in order to expand choice. You have to make sure that the implementation is supported by rights literacy and rights monitoring and accountability mechanisms, but often the pieces that are necessary don't cascade down from the policy. Other challenges, policy challenges, are the ambitious numeric goals that governments commit to. I have been in workshops with program managers, and there's been a total dissonance between the numeric targets to which their institution has committed, to which they feel bound, and their intention to support a rights-based program. They have trouble reconciling that, and they speak inconsistently with their staff. So it's a matter of helping people understand what this means and then ensure that at whatever level they operate and have responsibility, that what they do and what they say is consistent with a rights-based approach, because sometimes it's at the rhetorical level, but it isn't made practical.
I just want to add very quickly to Lynn's comment. I agree that the aha moment with providers has been very valuable in KADUNA, and I'm very glad that we included this now kind of demand side component. Okay, sorry, I was thinking my mic went off. The demand side component really is critical because despite facility staff having that aha moment, we run into these inherent or long-standing health system challenges. For instance, not having enough funding to buy IUD kits, or not having enough money to make improvements to the facility so that there's actual privacy. Even a simple thing as purchasing a curtain so that there's visual privacy. We run into those financial challenges, so there's only so much progress we can make on that facility level. And so by now having the demand component, and we're actively, where these facility health committees are actively raising funds from within the community, voluntary donations, we're talking about very small sums of money, but those resources are now being used to fill gaps of the public sector. So that combination, I think, is working most effectively in KADUNA and where we've seen most success.
Thank you. We've got another one. These are not easy questions, people. Samya Ramarao wants to know if we have evidence of rights-based approaches on getting non-users to use family planning or visit health centers.
I will just chime in on the KADUNA front. We are collecting a lot of evidence. Let me just say that shout out to Karen Hardy and the Evidence Project, and they developed this fantastic service delivery rights-based family planning index. And we're using that at baseline and end line to evaluate the impact of our intervention. However, one of the components of that actually looking at the number of users is not part of that survey, but we are separately in KADUNA looking at service statistics, looking at them by month, and so we're able to see and compare how user profiles change in our intervention and our control facilities. So if we have an influx of new users for X method in an intervention facility, we're going to try to kind of disentangle that effect and see whether or not it may overlap with the intervention period and how our intervention may have had an impact on that. But we do want to say that the numbers aren't the big driver here for us. It's about making sure that the enabling environment for family planning and rights exists and is there, and by extension, you would see uptake.
Thank you very much. And now Megan Christofield says, thanks for the slide illustrating the difference between business as usual and added focus of a rights-based family planning approach. Many would argue that high-quality programming includes those added foci, even when not framing it as RBFP. What are your thoughts on that?
Okay. Oh, I got it. That's a great point. And, you know, we could probably argue about what's included in quality of care versus what's included in a rights-based approach. And my point of view is as long as all of those rights and rights principles are programmed and deliberately programmed in a program, frankly, I don't care if it's called a quality of care approach or a rights-based approach. But I do think that the issue about participation and accountability and that question of equity, who is and who isn't getting services, isn't always explicit in the quality of care approach, which is looking pretty much at service delivery and the system itself. And some of those other sociocultural barriers and the things that happen outside the clinic and prevent people from getting to the clinic, or what has happened at the clinic and its implications afterwards, may not always be holistically programmed in a quality of care approach. But if I'm fine with those principles being programmed and calling it whatever it needs to be called, as long as we're paying attention to those important rights and rights principles.
Yeah, just a quick word on language. There is not one accepted definition of quality. In fact, there's a paper in the compendium of that the Evidence Project published, which compares quality of care models and the rights-based approach. So you might be interested in looking at those definitions. But the issue of language comes up a lot. How do people define quality versus rights? How do people talk about this? And another point that's worth making is that in some settings, the use of rights language can be sensitive, and we're fine with not using the rights legalistic language. If people are more comfortable talking about things in the programmatic language with which they are familiar, which is more acceptable to government counterparts and in certain cultures, that's fine. We just want people to understand the principles and to be protecting them. And governments have made commitments to fulfilling these rights for their citizens. So we're trying to help programs move in the right direction. And that starts with how the programs are designed and monitored and held accountable.
Thank you, Jan. And given the volume of questions, we'll extend and take one more. And we've got a good one. How do you challenge religious barriers to contraceptive use?
Well, from my experience in KADUNA so far, I think for those of you who know Nigeria, you know, of course, it's very culturally and religiously diverse. KADUNA itself is very much divided into a Muslim north, Christian south, and we see greater uptake of family planning in the south, less uptake, of course, in the north. And we've been expecting challenges, but I have to say we've been pleasantly surprised. To give you a few examples, we developed these materials on rights-based family planning, those 10 terms, and we translated those to Hausa and ensured that they have images of individuals from northern Kaduna, and people have been very receptive to that. We've also invited religious leaders to our facility health committee and that work, and they're actually active members of this FHCs. And we have imams standing at the end of this 3-day workshop and saying very clearly that they will bring this message of rights-based family planning and family planning overall to their congregations. I'm not sure of the appropriate term there, but so the opposition hasn't been very severe. I would just make one other point. We have had in a few cases needed to use the term birth spacing or child spacing in lieu of family planning. So that's been an adjustment that we've made, but nothing very intense.
Our last question, and let me just remind you that we will share the slides and recording of the webinar. We've already gotten a lot of questions for them, and they will be online. But our last question is, are there examples of collaboration with other approaches in the FGM and child marriage sector that intuitively would be more efficient in changing cultural norms? And
I'm not aware of any examples, but I think that's a great point because one of the slides we have but didn't show because of time is how important it is to work cross-sector and to look for partnerships that go beyond just delivery and healthcare to education to other sectors and areas that are working on other things. So I think there are probably efficiencies working with people on other sociocultural issues. There are efficiencies that could be had working with the education sector, with other sectors. So I think that's a great point. But I don't have any specific examples of that in the work that we've been doing.
Thank you very much. And I want to thank everybody that was online and on the phone. It's really been a huge turnout and a lot of really provocative questions. And if we didn't get to your question, we can do a follow-up later on, and we'll get back to you. And I just want to remind you that this is the first of several rights-based family planning webinars. And I have the brain trust sitting next to me that will be helping to come up with some issues that we can explore. And maybe some of these linkages and partnerships would be a good thing for us to look at. But I want to again thank Lynn and Jan and Kaya, and particularly Palladium and the Evidence Project and USAID and the Gates Foundation for their support for what we're doing and what we're trying to do. And thank